Good afternoon and good morning, everyone, and thank you for joining the webinar, Addressing Concerns and Responding to Myths About Safety During Crisis Calls. We'll start this webinar in a few moments to account for late sign-ons. Good afternoon and good morning, everyone, and thank you for joining us for the webinar, Addressing Concerns and Responding to Myths About Safety During Crisis Calls. My name is Deirdre Assay, and I am a Senior Policy Analyst at the Justice Center and will be moderating today's webinar. Next slide. To give you an overview of the webinar today, we will start by introducing the speakers. Then I'll turn things over to Caroline Huffaker from the National Policing Institute to talk about the types of collaborations and common misperceptions about safety during crisis calls for service. Then we'll hear from Dr. Cherilyn Lee about what this looks like in practice in Santa Barbara County. We will close the session with time for questions. We encourage you to enter your questions into the Q&A box on your screen. We'll try to answer any technical questions as we go and then turn the content-related questions during the Q&A. And I want to note that we are recording this webinar, and a recording should be available on the Justice Center's website in the next 2 weeks to account for the holiday. Next slide. We're excited to be hearing from presenters from the National Policing Institute and the Santa Barbara County Sheriff's Office. I am Deirdre Assay, a Senior Policy Analyst with the Council of State Governments Justice Center. I will ask our presenters to tell you a little bit more about themselves, and I'm going to pass to Dominique.
Good afternoon, everybody. My name is Dominique Burton. I'm a project associate at the National Policing Institute. I pass it over to Caroline, and then later on, we'll talk more about the Institute.
Hi, everyone. My name is Caroline Huffaker, and I have the privilege of serving as a Senior Program Manager here at the National Policing Institute. And shortly, I will be sharing with you about the myths and also introducing our featured speaker, Dr. Lee. Back to you, Deirdre.
Thank you so much to all of our speakers for joining us today. Next slide. So at the Council of State Governments Justice Center, we are a national, nonprofit, nonpartisan organization that combines the power of a membership association, serving state officials in all 3 branches of government with policy and research expertise to develop strategies that increase public safety and strengthen communities. Next slide. We work by bringing people together, driving the criminal justice field forward with original research, building momentum for policy change, and providing expert assistance. Next slide. Our goals are to break the cycle of incarceration, advance health, opportunity, and equity, and to use data to improve safety and justice. And there's a little bit more about each of these here. Next slide. Our equity inclusion statement, the Council of State Governments Justice Center is committed to advancing racial equity internally and through our work with states, local communities, and tribal nations. We support efforts to dismantle racial inequalities within the criminal and juvenile justice systems by providing rigorous and high-quality research and analysis to decision makers and helping stakeholders navigate the critical and at times uncomfortable issues the data reveal. Beyond empirical data, we rely on stakeholder engagement and other measures to advance equity, provide guidance and technical assistance, and improve outcomes across the touch points in the justice, behavioral health, crisis response, and reentry systems. Next slide. Today's webinar is funded by the Bureau of Justice Assistance. The U.S. Department of Justice's Bureau of Justice Assistance mission is to provide leadership and services in grant administration and criminal justice policy development to support state, local, and tribal justice strategies to achieve safer communities. BJA works with communities, governments, and nonprofit organizations to reduce crime, recidivism, and unnecessary confinement and promote a safe and fair criminal justice system. Next slide. And today's webinar is brought to you by the Justice and Mental Health Collaboration Program. The Justice and Mental Health Collaboration Program, or JMHCP, promotes innovative cross-system collaboration and provides grants directly to states, local governments, and federally recognized Indian tribes. It is designed to improve responses to people with mental health conditions and substance use disorders who are involved in the criminal justice system. Next slide. And I'm going to turn it over to Dominique to talk a little bit about the National Policing Institute.
Thank you again. Once again, my name is Dominique Burton. I'm a project associate working in the local programs division at the National Policing Institute, formerly known as the National Police Foundation. The Institute is an independent, nonpartisan, and nonprofit research organization, sometimes referred to as a think tank, focused on the pursuit of excellence in policing through science and innovation. Our research and our applied use of research guides us as we engage directly with policing organizations and communities with technical assistance, training, and research development to enhance safety, trust, and legitimacy. Turn it back.
Great, thank you. Today, during today's session, attendees will acknowledge the common misconceptions about safety during crisis calls for service, be provided evidence-based practices, solutions for collaborative efforts, learn what this looks like in practice in Santa Barbara County, California, and be provided peer exchange opportunity for agencies to discuss current programmatic successes and challenges with subject matter experts. Next slide. And now I will turn it over to Caroline. Thank you, Caroline.
Thank you, Deidre. All right, so first we're going to talk briefly just a little bit about the different types of collaborations before we head into some of the myths that maybe you as a participant have heard in your own community or have heard just in general in the field when we talk about cross-systems collaborations like police and mental health. Next slide, please. So why is it important for us to highlight evidence-based practices? As we all know, in 2020, there were a lot of events that took place in the life of our country that had mental health, police, public safety, multidisciplinary work on the forefront of everyone's minds as we navigated responses to the events in 2020. And it just so happened that at that time, the American Psychological Association, or the APA, put forth a declarative statement that recommended increasing the number of mental health and police collaborations across the board in our communities, along with other policing reform suggestions. And so in light of that, a lot of agencies moved towards these cross-systems responses, and a lot of conversations took place around what different response models could look like. Next slide, please. And so one of the outgrowths of the National Conference of State Legislators came this image that you see in front of you, which kind of encapsulates all of the different police and mental health collaboration options that agencies and communities can employ. You might find your community reflected in this image, or you might have an amalgamation of a number of these types of response models. The first being that of crisis intervention teams, or CITs. A lot of public safety and law enforcement agencies utilize these. This is comprised of law enforcement officials being trained on mental health and appropriate de-escalation techniques, different considerations and etiological factors in the development of mental health needs, and utilizing skills from the mental health field as just part of their tool belt as a public safety official when they engage with someone who might be in a mental health crisis. Then you move to having actual co-responder models. This might be where you have two folks paired up, one being a public safety professional, law enforcement, and someone from the mental health or social services field, co-responding in teams to calls for service related to mental health. You might have mobile crisis teams. So these are usually going to be community-based mental health programs You know, in my community, we have something very similar called a Maramed, where you have mental health and actually medical professionals that are deployed in lieu of law enforcement going out when a call for service comes into a local 911 center. You have case management teams, so this can look like a multidisciplinary working group or collaborative group between law enforcement, mental health, behavioral health, social services, and other providers in a community coming forward to staff and cross-collaborate on cases that perhaps one or more of their agencies is engaging with. And then you have crisis stabilization centers. So this can look like 24-hour walk-in clinics for folks who might need services and support. It might be that law enforcement brings individuals into these crisis stabilization units. They can serve acute needs and then refer individuals for long-term mental health and health situations or situations that would require long-term health care. Next slide, please. And now we're going to just enter into the part of our presentation where we're going to talk a little bit about some of the myths that you might have encountered and how you can actually use the Police and Mental Health Collaboration Toolkit that was published under this grant with BJA that you might be able to utilize and counter some of those narratives that maybe we hear that might prevent us from engaging in this really meaningful work. So next slide, please. We want to educate ourselves by debunking these myths. We want to understand the lasting impacts that these myths might have. You know, history is powerful in our communities, and if we're ascribing to myths or perhaps incomplete narratives about what these collaborations could look like, it might stop progress before we're actually able to get started. And of course, we want to increase and foster more collaboration between police and mental health professionals. We believe that, you know, a lot of the needs of our communities are multifaceted, of which all of us play an integral role. And so increased collaboration and partnership across multiple systems provides better public safety and better public service to those in our communities. Next slide. So the first myth that you may hear, I know I have, is that behavioral health conditions, individuals experiencing those are violent if confronted, and they might leave unarmed first responders, such as a co-responder, a mental health provider in the field, at risk of injury. So what we have found, next slide, is that in the Police Mental Health Collaboration Toolkit, there's actually a fantastic article that sets up a framework for this. It's called Police Mental Health Collaborations, a framework for implementing law enforcement responses for mental health needs. What we have found, what the data has shown us, is that when you employ police mental health collaborations, such as like a CIT program, for instance, officers are better able to understand and interpret crisis behavior or crisis-related behavior and respond appropriately, which leads to fewer injuries to that community member. It leads to fewer injuries to that officer. And of course, if you have a mental health provider on scene, they are able to come alongside that officer and utilize both skill sets of public safety and mental health providers to create a more streamlined response. It also, these types of models of cross-systems collaboration has allowed for a reduction in injuries and also has increased the engagement that individuals have with community-based programming. And so it's just really important to, you know, break down some of the myths that we have, particularly as it relates to safety of officers and providers, but also to constituents themselves. And what we see is that increased collaboration actually results in fewer injuries. And you can find that actually on page 3 of the document that I referenced, if you're interested in looking to see where exactly I found that. Next slide, please. The next myth that we have is that if you choose to have a co-responder, this will simply tie up officers and resources on scene. So how we're going to debunk that is next slide. What we actually have found is that it creates a greater efficiency in call response and getting officers back out in service when they are a part of a police mental health collaboration. So what this could look like, and of course, Dr. Lee is actually going to show you a real life tangible example of what this looks like in action. is that when officers and mental health providers are a part of a collaboration, the officers are able to identify more efficiently the mental health crisis and then are able to divert that individual into crisis services, whether that's mental health, crisis stabilization unit, referral for case management, perhaps calling someone to the scene if there isn't a co-responder available. And so what we're able to find is that it allows for folks to remain stable. It allows for folks to engage with services over a continuum of care, and it makes officers more efficient. Again, if you look in the Police Mental Health Collaboration Toolkit, you'll be able to find evidence of this in the article I cited on the last slide, but also in the other resources that have been made publicly available. One note on this is that for folks that might be trying to establish buy-in with their agency around how this is a better use of resources, is that what the data has found and what we are finding is that to that second bullet point, that it allows individuals to remain stable, is it is really hard to demonstrate prevention methods that if we are able to get someone into supportive services now, will we be able to prevent a call for service 3 calls from now? And so what we are finding is that because individuals are then able to regularly engage and remain outside of the criminal justice system and be placed into a supportive scenario like crisis services, they're able to potentially cut off future justice involvement or future police engagement as a result of these collaborations. Next slide, please. The third myth that you may have heard or be hearing in your community is that police are called to handle behavioral health crisis calls and social disturbances because they are the only ones with adequate training and resources to respond to these calls. Next slide. And what we have found is, with all due respect to our colleagues in the law enforcement field, is that nothing could be further from the truth. I certainly have a tremendous amount of respect for Dr. Lee and individuals that work full-time in and around mental health, because it is an incredibly taxing and extensively trained field. Professionals in the mental health field have had extensive training, years worth of schooling, depending on your licensure, depending on your degree requirements, and they are trained on a whole host of assessment skills, de-escalation, how to effectively engage and communicate with folks, being able to suss out what is needed and make the proper connections and referrals. And it's worth noting that it takes 3 to 5 years on average for someone to become a licensed mental health provider. Big note for that is that it is going to vary state by state, depending on your state's licensure laws. So for example, in my state, it takes a 60-hour degree program. So anywhere from 2 to 3 years, depending on how quickly you move through a graduate program, 2 years post-graduation with 1,000 client-facing hours, 50 supervision hours with a clinical supervisor, and then an individual has to pass the National Counselor's Exam and the jurisprudence exam in our state. So that is why it takes such a long time for someone to become licensed in this field. And then if you have further designations, such as a mental health service provider, that's additional hours, that's additional credentialing that someone has to go through. I say all of that to say that mental health providers are extremely skilled at what they do. They are a resource and a tool for community and an equal counterpart to law enforcement in a public safety response. Absolutely, law enforcement is skilled and able and capable to do what they do. But it's important, if you have never perhaps engaged with a mental health service provider, to ask what are their credentials, to ask how long it took them to get to that place professionally in their careers, because there is an incredible reservoir of knowledge there, which is backed by schooling and degree programs that those professionals have engaged in. Next slide. Another myth that we often hear is that all community providers feel safe on scenes or in the community. So perhaps after 2020, you heard a lot of conversation around send mental health providers instead of police solely by themselves. And the reason that we want to perhaps debunk that a little bit is, as you will see on the next slide, is that support for mental health providers can vary from agency to agency. Just like law enforcement training can vary state by state, agency to agency. I know that even in my jurisdiction that I live in, one agency has their own police academy and one sends them to the state academy. And while similar, there are some stark differences. So too does that happen between agencies in the mental health field. So I think it's safe to say that if you are going to engage in a police mental health collaboration, whether that be co-responders, having a mobile crisis unit, is to understand that some agencies might do a really thorough job of training and supporting their staff by providing safety planning options, self-defense training, harm reduction methods, and that may be really, really present at one agency. And then if you have another mental health agency in your community that you're engaging with, they may not have provided their staff with as robust of skills or resources. And so again, asking your partners, what is their training around that? Perhaps there's something that you as a law enforcement entity can do to come alongside that mental health agency and provide their staff with self-defense. It's a two-way street when it comes to cross-training with one another. And so that might be a great place to explore is what does safety look like for those that may not feel as comfortable on scene, or teaching them situational awareness when they are on scene. Where do you park your car if you do come and respond on scene with me? Where do you position yourself in a room? Again, because some folks may have had that training in their mental health training or degree programs or in their agency, and some folks may not have. So it's important to, debunk that for yourselves by not assuming that everyone automatically feels safe. Next slide, please. So some other helpful data or points of consideration to look at when you are perhaps going to implement a police mental health collaboration, or if you're already in the throes of doing that, especially if you're having to establish buy-in from a leadership level, is look and pull your own data. Look at rates of request for police backup, and maybe separating those calls out due to the perception of danger, or if there was a concrete threat or risk to any of the individuals on scene. Maybe if you do have staff injuries, is looking at what types of injuries were caused, if there are, if there's a pattern in the location of them. So was it a residence or was it in a public space like a parking lot? If you don't already document injuries, probably from an HR perspective, that would be really helpful. So you can have a first reported injury form. A lot of police agencies do that. And so you might want to consider how you track those methods and pulling that information if you do. And then of course, where the injuries take place. Next slide. As I said earlier, learn the licensure requirements for mental health providers in your area and be willing to check those credentials, right? A lot of us have different credentials. So if there is a difference between an LCSW and an LPC. There's a difference between someone who's maybe a licensed marriage and family therapist, an LMFT, just like there's differences between a CIT trained officer and someone who is SWAT. Everybody has lots of letters following their names. We are all very proud of the trainings that we have received, but making sure that if you are going to engage with mental health providers, checking those credentials and understanding what that does and doesn't allow them to do in your state. For example, in our state, there's a designation between an LPC and then, which is a licensed professional counselor, and an LPC MHSP, so mental health service provider. The latter of those allows someone to diagnose. If I am simply acting or providing services as an LPC in my state, which I'm not, by the way, but if I was, that would mean that I can help folks with, by statute, by law, I can help folks with a certain number of issues. And then if there is a need for a diagnosis, I need to refer them, right? So I say all that to say, again, for the purpose of your planning in your community is understanding what those designation needs, what are the needs of your community, how do you want your collaboration to function, and then plan accordingly. It's always helpful to conduct a review and gap analysis of your training curriculums so that you can look for cross-training. So a great example would be the one I just mentioned a few slides ago. Could your local law enforcement agency come in and help do some situational awareness, environmental design training, and self-defense training for a mental health agency in town, right? I used to work at a law enforcement agency and thought I was pretty good about safety planning until I worked with law enforcement and realized there was a lot that I was leaving unattended to in my own personal safety as a social service provider. So there's a really great opportunity there for you all to keep each other safe, and then to increase the capacity of your services by constantly reviewing and assessing how are we doing, what are the areas in which we need to have more procedural interaction between our two professions. And then use data health points to create that system for better response to mental health crisis calls. So all of the data that you gather, whether it's the number of calls for service, the duration of that time, and then the number of requests or referrals into a crisis stabilization unit. What are you going to do with that data to chart and make a plan? Because what you want is for that data to inform your actual practice of cross-systems collaboration. Next slide. And so now I have the distinct honor of introducing Dr. Cherilyn Lee. Dr. Lee is the Behavioral Services Manager at the Santa Barbara County Sheriff's Office, and we've had the joy of partnering with her on webinars before. For those that haven't had the opportunity to hear from her, Dr. Lee has actually been in her role first as a volunteer going back all the way to 2015. So she predated the APA in 2020 by saying folks needed to increase collaboration. She's been doing this for a long time. She started as a volunteer, went to part-time work, and now is a fully embedded practitioner and clinician in the Santa Barbara Sheriff's Office. The reason that's important, I think, to highlight is that clearly demonstrates their jurisdiction's commitment to having police and mental health collaboration, in which now, I believe, I hope I'm not speaking out of turn, they are fully funded by their agency and have successfully transitioned themselves off of grant funding, which means they're a permanent fixture of public safety services there at the Santa Barbara Sheriff's Office. So I'm going to turn it over to you now, Dr. Lee. Thank you so much.
Thank you, Caroline. I very much appreciate that introduction. And I think we can say fully funded. So we are there. So appreciate it. We'll go ahead and go to the next slide. Thank you. So I am more than happy to present today on the Santa Barbara Sheriff's Office Mental Health Co-Responder Program that we have. I'm also would be remiss if I didn't mention our wellness program that we have at the Sheriff's Office. It's a big part of my heart to be providing counseling and nutritional and exercise support for our deputies who are out doing the hard work. And so threw in there an emblem of our peer support team as well. But we can go ahead and go on to the next slide. Okay, so a little bit about me. So I am a full-time employee at the Santa Barbara Sheriff's Office. Within that capacity, I am actually a manager. So I supervise the sworn unit of deputies that respond to the mental health crises out in the field. I am on our crisis negotiation team. And so whenever there is a SWAT call out, our crisis negotiation team gets activated and I get to go out on scene and assist with collecting intel that might help us resolve this circumstance and situation peacefully. I do a lot of behavioral threat assessment for our organization and allied agencies. And so it's often the case that we get folks with a history of behavioral health stuff, and that person might be evidencing behaviors or making statements about committing violence in our community. And so I have a hand in assisting our law enforcement folks get a handle on those cases. I do all of the CIT training or crisis intervention training for law enforcement within Santa Barbara County through the Santa Barbara Sheriff's Office. I also supervise our medication assisted treatment program for our inmates who are addicted to opioids and similar substances. Gosh, what else? I oversee our wellness program and our peer support program at the sheriff's office as well. In addition to working at the sheriff's office, I have a private practice through an organization called the Counseling Team International, wherein I see first responders only, and I specialize in treating post-traumatic stress injury. Some of you on this call might know it as post-traumatic stress disorder. However, I think that that word is an inaccurate depiction of what actually happens in the brain and body as a response to incidental and or cumulative trauma. Through my private practice, I also get the honor of being deployed throughout California to respond to critical incidents and conduct critical incident stress debriefs for natural disasters, line of duty deaths, kit calls, and so on. I'm contracted with Santa Barbara Police Department for negotiation services as well. And I have the honor of working with our state post on as a subject matter expert for officer and dispatcher wellness, and have been published as an author on various topics, mostly inclusive of co-response and wellness as well. Next slide. All right. So our county co-response program started in 2018, and we have 3 primary objectives for our deputy and our clinician that are paired together. They are to respond to mental health crises that are coming through 911. They are to engage in what's called proactive contact, so meeting with folks that may be pre-crisis, so they're not at the level where a 911 response would be indicated, but perhaps they're evidencing behaviors of decompensating, not taking their medication, and they have a history of criminal behavior. And then following up. So once somebody goes to the psychiatric hospital, or we divert them from the criminal justice system into some corner of treatment our county offers, we want to also follow up with that person and ensure that they're maintaining their level of service, depending on the circumstances that led us to meet with that person initially. Our co-response program at present is inclusive of a deputy that I supervise for deputies. And one of our clinical partners, so a licensed clinician from our Department of Behavioral Wellness, which is our county mental health department. I do not go out in the field. I do not conduct the assessments. I'm a manager. And so I help field the team and provide them with the resources they need to do the work. Next slide. So I'm going to be presenting some data based off of calls for service that were in 2020. The reason why I'm presenting data from 2020 is because we have the most robust outcome slides for our program from that period of time. I am looking at getting the same robust slides for 2021 and 2022 in the next month or so. And so happy to follow up as is requested by this group or members of this group to provide more current data. But for this presentation, I'm going to talk about what we did in 2020. So in 2020, generally speaking, our sheriff's office fielded about 3,000 mental health crisis calls. Of those 3,000 mental health crisis calls, one of our 3 existing full-time co-response teams handled about 1,600 of those calls. Out of those 1,600 calls, we identified through treatment records through our county mental health system that we touched about 496 individual persons. So as I refer to the cohort in the subsequent slides, I'll be referring to those 496 persons that were served. This slide is a bit busy, but what it shows you is if you look at the left-hand side where you see the word cohort in 496, it mentions how many persons within the cohort have a history of treatment with county mental health. And that's inclusive of childhood as well as adult engagement with our county mental health system. So over 415 people that were contacted had already established some level of service with behavioral wellness. 141 had touched our jail at some point between 2016 or the event where they encountered our team in 2020. And then 22 of those persons were engaged in our newly established sobering center, which has been up and running since 2020 as well. Next slide. So some of the data related to who it is we're interacting with. So on average, the cohort, we're interacting with persons who are about 38 years of age. About 56% self-identify as not having a permanent residence, which doesn't necessarily indicate homelessness in the traditional sense of the term, but indicates they don't feel as though they have a permanent residence at the time of contact. Most of them are male, most of them are white. A significant minority have graduated or received a high school diploma or equivalent certificate. Most have had an admission to behavioral health services prior to our contact with them. Some have also had admission into our alcohol and drug services in the county. In our county in Santa Barbara, the mental health and drug services are somewhat bifurcated. And so there's separate admissions that have to occur for each of those domains. Then most of the persons that we encountered in 2020, we encountered one time. Of course, we have folks that we encountered multiple times, but those were the exception, not the rule. Next slide. So out of the 1,606 contacts that were made by one of the 3 co-response teams in 2020, only 11 times was somebody arrested. So out of 1,606 contacts, somebody went to jail 11 times. That's a pretty impressive, from my where I sit, impressive number. What that meant is that most of the people that were taken, that were not taken to custody, on the next slide, we'll show you kind of what we did with them. But for the 11 folks that were taken to custody, I think it's important to mention our co-response team does not do the arrest. If an arrest needs to occur, it is patrol that comes in and will take that person into custody so that we can maintain a positive relationship with them if we encounter them again, which oftentimes we do. So on the left-hand side, you see co-response related arrests. On the right-hand side, what you'll see is that bar that says arrested is indicative of the cohort. So the cohort, when patrol was responding to a call for service, the cohort was experiencing a higher number of arrests than when co-response was involved versus patrol. That could be indicative of there was a different interaction. Perhaps that the reason for the patrol request was that there was a criminal activity unrelated to behavioral health stuff, or perhaps the patrol deputy felt that an arrest was more appropriate than a diversion to treatment for whatever reason. I think it's also important to mention that for our county, we are the only county in California at present where our law enforcement officers are not authorized to write their own psychiatric detentions. So they do not write 5150s, which is the WIC code, Welfare Institutions Code for psychiatric detentions for our state. I'll go into that in a little bit more detail in a subsequent slide. Next slide. So everything else. So if somebody's not going to jail, but they're engaging with our team, we want to ensure to the best of our ability that they have the resources that they need to get through the crisis that's occurring right now, and that we provide whatever support might be reasonable and necessary to prevent future crisis. So sometimes that is mental health services, taking somebody to a clinic, an appointment, connecting them with their established provider. Sometimes it's helping the person with transportation to where their destination might be. Social services, substance use support, housing. We will at times take persons to the DMV to help them get their driver's license so that they can get into a shelter within our community. So our program is really in existence to do whatever is needed, whatever else is available to help that person move through their crisis and out of the criminal justice system if safe and appropriate to do so. Next slide. All right, so our teams at present, we have 3, and they work split shifts, and they work from 8 a.m. until 6 p.m. The reason for the days of the week that they work and the times of the day that they work is because of the data that we have received through our CAD system and dispatch that informs us when our department has the majority of our mental health calls for service. So we know that the majority of our mental health crisis calls come in Monday through Friday, and they come in 8 a.m. to 6 p.m. It is not, we did not create bankers hours, if you will, for the crisis teams to encourage people putting in for the position. This just happens to be what our data is telling us the need is. And should the data change, so will how we staff the teams. Next slide. So what this slide shows is on the left-hand side, you'll see that in 2020, when our co-response team is working, we are able to handle almost 70% or more of all of the mental health crises that come through 911. So these are calls for service that would have otherwise been handled by patrol. When our team is engaged, patrol is released to be able to do other law enforcement duties. And so we're able to take a huge workload off of our patrol deputies who would otherwise be on scene with the person in crisis. And then you can see that when our co-response teams are not working, they handle a lesser number of calls. On the right-hand side, we have the time of day based on call type. So our three most common call types for our mental health crises are suicidal subject, check the welfare calls, and then our sort of catch-all dispatch term would be all other. So that's everything else. Those are the three most common call types. So we're able to look at our data and mine through when these call types are occurring as well, which helps us deploy the teams at targeted times. Next slide. So in addition to the general calls for service that our teams handle, the teams are also very busy in terms of working with our call outs. So folks that are barricaded and suicidal perhaps may have been a full SWAT call out, negotiations call out 4 years ago, but now we're able to deploy a lesser and more targeted response to those kinds of calls for service. And so our team will assist on an as needed basis. Our team assists with CIT trainings and de-escalation trainings. We have worked with our nonprofit partners within the county, as well as our other county partners, to train them in de-escalation tactics. I think Caroline was mentioning earlier that depending on your licensing, your training, your experience where you went to school, you might get a lot of really good information from as a clinician on how to work with somebody who's in your office, who's ready to engage in a therapeutic conversation. You may not have received information on positioning or how to de-escalate somebody who is standing across the room holding a weapon. And so what we're able to do is provide that sort of ancillary training to our partners in hopes that they feel more comfortable and confident de-escalating these kinds of circumstances themselves, so that perhaps that will avoid an unnecessary call to law enforcement. Now, if somebody's standing at the other end of the room with a knife, that would likely be an appropriate call to law enforcement. But for lesser kind of engagements, we want our community partners to feel empowered to do some de-escalation themselves. We work quite closely with our intel unit on cases of potential mass casualty or persons who are, I'll give an example, high school students who are clinically depressed, who have expressed a want to resolve their grievance by committing a school shooting. Perhaps that the intent to commit the school shooting or the intent to commit an act of violence is not meeting a criminal threshold, but it is clear that an intervention is warranted or necessary. We will engage with those folks to try and divert them from the pathway to violence. In California, we have a red flag law called gun violence restraining orders. Our team, our co-response units are the most expert on those civil orders, which allow for sort of like a domestic violence restraining order. It separates somebody from their guns for a period of time, and then there can be stipulations or court processes that the person can move through to get their weapons back if they so choose. We will assist with our civil department when they're doing evictions of persons who have known mental health and or substance abuse histories. And then we also will work with our city counterparts who have upstood their own co-response teams. So the sheriff's office first upstood our co-response team in 2018. And then in 2021, 2 of our local police departments have also started their own programs. And so we assist each other, case consultation, and provide coverage and mutual aid when indicated. Next slide. Okay, can we go back to the other slide? There's a few more things I would like to add. Thank you. So I think it's important to mention that the benefit of our co-response program is one that is a benefit to patrol, community, and our behavioral health partners. One of the ways that our program is a direct benefit to our own agency at the Sheriff's Office is that we have less resources that are needed when we have that clinician embedded with us. An example, I mentioned our 3 most common call types: suicidal subject. On average, for patrol to respond to that call type, it takes about 3 patrol units and 120 minutes to disposition the call. So from beginning to end, about 3 cars on scene and about 120 minutes from beginning to end. When our co-response team is responding to that same call type, on average, we'll have 1 unit, and on average, we'll disposition that call within 66 minutes. That's a big difference. It's a big resource savings. The reason we feel that that is the case is because of what I briefly mentioned earlier. In our community at present, our law enforcement officers are not authorized to write 5150 holds. So if I, as a peace officer, respond to a call for service for Caroline, who's expressed that she's feeling suicidal, and I recognize there's probable cause for a psychiatric detention, I have to call my partners over at Mobile Crisis or County Mental Health to respond on scene, conduct the evaluation, and determine if a hold is needed or not. That process of just responding on scene can take from 10 minutes to 3 hours. And so one of the reasons why it takes so long for our patrol deputies to be able to disposition these types of calls is because of that response time. Now, through co-response, we have a clinician that can roll code 3, and we're better for it. So that's, I think, one of the benefits of the program that's a direct benefit to us as a law enforcement organization. I will also add that from a treatment perspective, in the 6 months after the co-response contact, so I'm a deputy, I respond to Caroline, who's suicidal. We take Caroline to treatment. We can follow Caroline from that point of contact where she and I met 6 months beyond to see what's going on in her life in terms of the intersection of criminal justice and mental health. What we know based on the cohort, 496 people from 2020, is that bookings for the cohort reduced by 41%. Only 13% of the cohort was arrested within 6 months after their co-response contact. 24% more individuals engaged in mental health services. So 24% of the cohort was still engaged in mental health services 6 months after their initial contact. Most of those services were non-crisis, meaning they were outpatient treatment, which is a cost savings to our mental health department. And then I like to say, we saved lives. There's a brief story that I will mention, and then I have 2 more data points to share, and then I will stop the talking at y'all. So there was a call for service we had of a 23-year-old man named Nicholas, who's not his real name. He had texted his best friend in another county and said that he was going to kill himself. He was sitting on a tree, had a rope around his neck, and was saying his goodbyes. So his best friend called us, and we set out on a search for Nicholas. We did what's called a ping. We got a warrant and authorization to find where he was using cell phone data. And when we did, he was in a very remote location of our county. It actually took fire using chainsaws to get to him safely. So our team saw Nicholas, who was in fact sitting on a tree with a rope around his neck. Our clinician identified pretty quickly that he was very committed to the intent to kill himself. Our deputy sort of stayed back a little bit so as to not create the exigency or put pressure on Nicholas, if you will. So as soon as our clinicians started engaging in communication, our deputies were engaging in finding resources and getting them to the scene. So after about 90 minutes of communication, unfortunately, Nicholas decided that he was going to attempt suicide. So he jumped right in front of our clinician. Within less than 4 seconds, our deputies had slid down the hill they were standing on out of view and cut the rope from his neck. Within minutes, like I mentioned, fire had to use chainsaws. He was on a backboard being placed in the ambulance on the way to the hospital. And because of our co-response intervention, we believe that Nicholas survived that encounter, because had we not had the team together, and we had law enforcement on scene, our behavioral health partners may not have been able to find where we were. And so I'll share a brief quote from Nicholas's parents, who came into the station 4 days later to say thank you. The events of this last week, although extremely trying, have reinforced our faith in God and in humanity. Indeed, there were so many miracles and events we believe were divinely orchestrated, using individuals like your team to bring Nicholas to the point where he can find help, through that help find healing, and through healing find hope. If Nicholas had to go through the painful situation he did, he was in the right place and saved in exactly the right manner. That's why we do it. Last couple of data points, and then I will sit back. In 2022, between January and September 25th, our sheriff's office has fielded 3,913 mental health crisis calls. So just in the first 9 months of the year, we have surpassed all of 2020. We are seeing a huge uptick in the volume and acuity of these kinds of calls. One of our 3 co-response teams, we responded to 989 of those calls, or 25%. And of those, only 43 arrests occurred, which is less than 0.5% of calls for service. So we're seeing a higher volume and acuity. We're still seeing a relatively low number of arrests. And to Caroline's point earlier, our 3 teams were grant funded, and we have a commitment from the Board of Supervisors to continue the funding for these 3 teams. And we're also adding 2 additional teams for the next calendar year. So that is the conclusion of the formal portion of my presentation. And so next slide. I see that it, oh.
I was going to say, thank you so much, Dr. Lee. Our first question in the chat was, can you repeat the statistic that you mentioned about engagement and follow-up treatment? Was it 24% of people who called crisis were in treatment 6 months later, or 24% of crisis calls who were referred to additional treatment were in treatment 6 months later?
So out of the 496 individuals that were contacted by our co-response team in 2020, 24% of the cohort 6 months after the encounter were still engaged in services with the Department of Mental Health.
Thank you. And then the last question in this was, is that publicly available?
The statistics?
Yeah, the data, yep. Mm-hmm.
Absolutely. I'm happy to send it to you all, to send it out, or happy to put my contact information in the chat so that folks can ask me directly.
Great, thank you. Do you want to remind people that you can chat into either in the chat or the Q&A? You can continue to ask questions for either Dr. Lee or Caroline. But as we wait for more questions to come, and we do have another question. Does your team do follow-ups?
Yes, we do. So our teams are very busy, as you might imagine, just listening to the radio, and they're often on a call, and there are 2 calls pending in the queue. And so we triage the calls and go to whichever is going to be the most, wherever we're going to have the most impact. When they're not running from call to call, they have a list of persons to follow up on. And so there's different ways that we receive follow-up information. We have at the Sheriff's Office established like field interview cards for mental health that we have thus far kept out of the hands of the District Attorney's Office and Public Defender's Office because they're considered notes. Hope there's no attorneys on the call, but in any case, they're our own notes. We have our own database. And so what deputies might do when our co-response team is not working is fill out one of those field interview cards for follow-up. So our co-response teams will review those cards at the beginning of their shift and engage with those persons, or if they might follow up on a crisis contact that they've had. So a good example might be somebody that was committed to committing an act of violence. They got treatment, they're feeling better. That 15-year-old that I mentioned, that's a real case. Our team plays basketball with him twice a week to maintain a positive relationship, and also to, I'll use a quote from one of my favorite deputies, test his temperature and see how he's doing on an ongoing basis.
Thank you so much. And it looks like there was a follow-up to that. So are you self-dispatching? And it sounds like you answered most of this. You're self-dispatching, being dispatched, or being requested, or all three? And it sounds like it's a combination.
It is, but there's a particular way that we determine which of those buckets we're doing when. So if it's a suicidal subject, we will start rolling regardless of the circumstances. We hear there's somebody who's actively imminently suicidal, we self-dispatch. For most other things, unless we know the person and our teams are sitting at the desk, we will wait for patrol or dispatch to call us in. The reason being is because what often comes over the radio is very different than what you have in front of you. And, our patrol deputies are supposed to be at any scene within a certain number of minutes. So patrol is often going to be first on scene anyway, because with 3 teams covering the whole county, we're often not going to be the first ones there just because of logistics. And so from car to car, our patrol deputies will call in, co-response and consult, or ask them to roll in over the radio. And then we will be requested that way.
Thank you. Questions are really pouring in right now. So the next one is from someone who is working with a police department and has a civilian unit, and they also do CIT, and they're interested in learning more about how to organize and collect data to effectively demonstrate outcomes, which I know we could probably do an entire webinar on. So if either you or Caroline have some quick takeaway points on this topic, I think that'd be super helpful. And then since you've included your information, I would encourage folks to follow up if they had additional questions.
So I'll say that we have 3 different data points that we use right now. We have the dispatch data through our CAD system, where we pull the raw data, how many mental health calls, where are they coming from, what times a day, how often are our patrol deputies and co-response teams responding. We then have an EHR, electronic healthcare system, that our clinicians hold. So they're entering all of the treatment data or demographic data. What was the reason for the call? Was the person suicidal? Was there a gun involved? What age are they? Then we also pull, 4 data points. We pull data from the treatment continuum within behavioral wellness, and then we pull our jail data as well. We've had the luxury or pleasure of working with an organization called Social Finance that we contracted with through the grant to sort of make sense of and synthesize all of these data points. And they've de-identified the data, so it's all HIPAA compliant, and that's how we get the outcome information back. But happy to speak more on that offline.
One other point too, Dr. Lee, I know you just mentioned that you contracted. And so for some folks, another area that they could explore partnerships is if you have a local college or institution with a criminal justice program, a social work program, a public health program, you might be able to partner with researchers, professors, and graduate students. If you don't have the funds to contract with an entity, you might be able to get some really rich data analysis from local institutions. And that's just another way to kind of broaden your partnership and bring other folks into the fold that could help with data analysis, which could then translate to policy development. And so if you can't, if you don't have grant funds or can't afford or don't have a crime analysis unit, that might be a really good option, is local institutions of higher ed.
Thank you both so much for such a well-rounded answer. And Caroline, you kind of are prepping us for the next question. So someone writes, I am currently writing policies and procedures for our mobile crisis response teams and looking for examples of other policies, procedures that teams have completed. They've reviewed info on our tool at the CSG Justice Center's Toolkit, but looking for more. Do either of you have some suggestions of where to find some detailed policy and procedure suggestions, or do you have something that you recommend, that you can talk about?
I will say that there's a lot of conversation at the federal and state level guiding these initiatives. I can certainly share what we have in our state and our county, because that's my span of control and what I have access to. But I know that there's a lot. I just came from Sacramento a week or two ago talking about this very thing. And I know there's going to be a lot of guidance coming down. But outside of that, I'm happy to send you what I have access to.
I'm also happy to send, this is more specific around 988 implementation, which we think there's a question around 988. And again, that's going to be different state by state because each state is responsible for rolling out their implementation of 988 with federal dollars. But that said, there's some really great stuff on SAMHSA's website. The name of the official agency is escaping me now, so I apologize for that. But one of the national kind of best practice agencies for 911 and dispatch also has sample policies and procedures specific to 988, but that kind of complements really nicely into co-response or police mental health collaborations. So I'm happy to, if it's easier to give that to Deidre and Deidre can then send it out, or if folks, I can drop my information in the chat as well. And then to Dr. Lee's point, I've never built a embedded mental health behavioral health unit, but when doing something around the lines of victim services within a law enforcement agency, peer exchange, what Dr. Lee just offered to do was one of my best resources, was finding agencies that really had promising practices and really had promising initial findings and results that perhaps could translate into my community and contacting them. So a lot of cold calling, but when you can find someone like Dr. Lee, who then might be able to put you into contact with another agency that's doing things really well, and then if they're willing to kind of share or at least hop on the phone with you for an hour, those peer exchanges are fantastic ways also just to build your network. If you're building an agency and a law enforcement entity or a public safety agency, it can be hard. And so creating a network too of other folks that have kind of walked that path ahead of you also is really, really helpful and can be really encouraging as you develop these really, really important programs.
Thank you so much. And you're right, there is a question about 988. So just to specifically ask it, has the event of 988 changed planning for co-response? And do you expect fewer calls for law enforcement to respond to where mobile crisis is responding with no law enforcement?
I'll speak on behalf of myself and not my sheriff's office. I don't expect the impact of 988 to really have an impact on law enforcement calls for service. And the reason being, somebody who's likely going to call 988 because they're asking for help because they recognize they're in a crisis is not likely the person that's also calling 911. And so I don't know that it's going to take a huge workload off of law enforcement, except that maybe in an indirect way, in that if people recognize they're not okay and get help, it'll prevent them from going into a crisis later on. My own experience, and I know it's a new program, and having written and developed new programs, there are bumps in the road, and I'm the first to admit that. It took me 2.5 minutes to get a live person on the phone. And that's a very, very long time. And so I'm a bit concerned that folks are going to use that instead of connecting with law enforcement. And so I'm navigating that, internally and with our local NAMI, National Alliance of Mental Illness group. And, we're sort of game planning what that means for us. But I don't know that it's going to have a big impact on law enforcement or co-response operations just because of the nature of the call. I'm also not quite sure how 988 is going to transfer those calls to us, because I think it's area code specific and not zip code specific. So I don't know that we're going to get a lot of work from 988, though I'm very much looking forward to our ability to transfer some callers to 988, which will relieve some of the impact that these calls for service might have on dispatch, where a deputy never even gets dispatched to the scene, but our dispatchers are kind of doing the crisis work themselves. So those are my thoughts.
Thank you so much. Our next question is, why is the percentage of people being served by the program in the program predominantly white when Black and Hispanic people are, it's saying 3.5 times more likely to be in jail, which I don't know if that's specific to the county, but can you talk a little bit about some of those disparities or what might be causing that?
Sure.
And to address.
Yeah, I can. I think anecdotally, Santa Barbara County is historically a very white community, with the exception of our North County, where at present we only have one team, and we will be onboarding a second team in North County to help with that perceived or real disparity, if you will. We have a higher number of crisis calls documented in South County, and that might be because just historically, folks are less likely to engage law enforcement, or less likely to be accepting of or appreciate that there is mental health stuff and reaching out for resources for mental health stuff. So that is the best answer that I have, just anecdotally, from why there is an apparent disparity in the data. I will say that that is a data metric we are looking at. I will also say that that is a data metric that comes from our behavioral health clinicians. And so when we don't have a clinician with us, they're sick, they're on vacation, so on and so forth, we don't get that outcome data. And so there are a large number of calls that are handled by our deputies working co-response when they don't have a clinical partner. So we're missing some of the raw data. And so that data point may be skewed in part because of that. But that is something we're looking more into. But anecdotally, I think it has to do with logistics of where the teams are located and who's more likely to call 911 because of a mental health crisis.
If I may add too, I think that I appreciate that question being asked, and then I appreciate the curiosity with which Dr. Lee and her team are approaching that. Traditionally in the mental health field and in the code of ethics for ACA, NASW is a commitment to cultural competency and cultural humility, and understanding how is it that we serve people in a way that isn't just engaging them, but it's also engaging them in services that meet them with their cultural considerations as a part of how we assess and engage folks. And so, that's a great question to ask in a webinar such as this. And that's a great thing that it's a data point that Dr. Lee and her team are curious about, because absolutely, folks might be less inclined to engage with a system that perhaps in their community isn't one that's traditionally sought out. Perhaps the history of that system with a particular community hasn't always been the most successful. And so what kind of conversations do you need to have as a community to reconcile yourselves as even public health or systems providers to communities that perhaps have had a difficult relationship with not just mental health, but health in general. And then you layer on law enforcement. So there's just as much, I think, a community conversation that can come out when we ask those questions to make sure that everybody in our communities feel as though they can access and are represented in the systems that are there to serve them. So remaining curious about what the data does show, so that, perhaps, again, you can address disparities and then bridge access or increase access for folks in the community that may not be represented.
Thank you both so much for such a thoughtful answer. There was a follow-up question about the ethnic and racial makeup of the team. So is that something that's been a priority for your team, is making sure to hire folks from diverse backgrounds, or is that something that you're looking to be able to do more in the future with setting up your second team?
Yeah, no, absolutely. When we started in 2018 as a pilot program, both our clinician and our deputy were African American. And so the makeup of the team changes depending on staffing. Right now, we have 2 folks on the team that speak fluent Spanish. Then that wasn't the case in 2018, but that's the case now. And so we're always wanting to have a diverse group of persons that are responding to crises. But I will also say, if we're responding to a Mixteco speaking household or another primary language, our co-response team will utilize one of our deputies or other clinicians who speak that language or who are embedded in the culture to help communicate with them if time allows. So we certainly use the resources we have available to us if we're not able to do that direct communication when it's safe and time allows to do so.
Thanks so much. I feel like, we've done other sessions together talking about hiring, and there's just so much overlap with training and hiring and being intentional about the folks that you're hiring together. We could really talk about this endlessly, but I think that we'll move on. So the next question is, does the sheriff's office also have access to mobile crisis teams? And if so, how have you worked with dispatchers to differentiate calls that should go to the police only, or maybe CIT versus co-response versus mobile crisis only?
So our mobile, how do I say this? We have had mobile crisis teams for decades, since at least the 80s. So I mentioned that our peace officers are not authorized to write by policy, by law they are, by policy, not write their own psychiatric detentions, or in California it's 5150. What we have is mobile crisis who can come in and do that instead. The makeup of our mobile crisis teams are anywhere from persons with lived experience that have had 8 hours of training, to clinical interns, to folks that are licensed practitioners. And so we really have a wide variety of persons that respond on scene. And unfortunately, we might have one mobile crisis person working for the entire county at any given time. And that's 450,000 people that are residents here. And that number is much, much higher during the day. We have a lot of our workforce commuting. And so though we have mobile crisis teams, they're not sufficient to meet the demand of our community. And so I really feel that co-response is a helpful adjunct to that. I would love for our mobile crisis folks to do more proactive work and more follow-up work. And we're currently, our county is currently considering restructuring some of the way we've done things because of how successful our co-response program has been. But I will also say that an interesting anecdote is our mobile crisis folks do not want to respond out in the field without law enforcement. And so it's been the case that they will say, well, is law enforcement there? If they're not there and have seen security, I'm not coming yet. And so, yeah, we have mobile crisis teams, but we've always sort of responded together anyway. It's just been a bit disjointed. And so I know there's a lot of talk about mobile crisis teams. I think having a team is great. I think it can really work against you to check a box. And I think, considering the utility of the team, your region, what resources you have or don't have are really meaningful when upstanding these types of programs, especially when it comes to crisis services.
Thank you so much. I've definitely experienced that as well. And I think that's kind of the kernel at the heart of this today is, how can we help, especially mobile crisis? Like co-response still has that law enforcement aspect. But are there any resources or trainings for mobile crisis specifically about safety on scene for folks that are not responding with law enforcement and may have some lingering concerns about safety, securing the scene, et cetera? Do you know of any national programs or continuing education for clinicians? Any starting point for folks?
I don't personally know of any existing programs. I will say that our co-response teams do de-escalation and safety training for our clinicians, for clinics, for our psychiatric health facility, our locked inpatient unit. So that partnership has allowed us to help our civilian counterparts understand better about safety. But I'm not aware of any formalized training. In our CIT training that we do for law enforcement, we always invite our behavioral health friends and practitioners to attend, and there is safety information and scenario-based training about safety embedded in the course. But that's about all I can contribute to that answer.
Thank you. And it looks like we're at our last question. So if anyone has any last minute questions, go ahead and get them in quickly, because we might be closing out the question and answer after this otherwise. And I'm going to take a stab at this one before I pass it on. But the question is, do you anticipate additional federal funding becoming available to support Coresponse? And I just want to remind everyone that this is a webinar funded by the Justice and Mental Health Collaboration Program. And for the first time for fiscal year 21, and again for fiscal year 22, under the JMHCP program, BJA released a separate bucket of funding called Connect and Protect that is focused on law enforcement. So Justice and Mental Health Collaboration Program is no longer serving law enforcement grantees. Those have been pulled out into a separate bucket. So more opportunities for folks across the Intercept map, but that funding is specific for law enforcement. It doesn't have to be co-response, but we've seen for the past 2 years that a number of the grant team cohort does at least include a co-response model, whether it's planning and implementation or expansion of an existing co-responder program. But I'll kick it probably over to Caroline to talk about any other funding opportunities that you're aware of.
Certainly not at the federal level, and I certainly don't want to speak without direct knowledge, but I think Dr. Lee and she can kind of expound upon this. I think one thing that you could strategically think about is if you were able to secure funding at a federal level, or even with like a state pass-through grant, like a formula grant through your Department of Health and Human Services. I believe Dr. Lee can kind of speak to how she used that as a proof of concept, essentially. So, if you utilize a federal grant or a state formula grant to kind of get your services up and running, and then approach your city council, approach your county commission or your board, and then say, look, this is the work that we've established in order for us to continue doing this work that provides a critical public safety service to your constituency. This is the cost savings that we have provided, and also these are the things that could potentially be at risk of going away. Certainly not in a threatening way of not saying, please don't go out and hold your city council people to the podium and say this is going to go away, but helping them strategically think through, right? Like, this is a critical component of what we have been able to provide citizens in our community. And in order for us to continue doing this, these are the potential cost savings if you provided an investment into public safety in this way. And particularly post 2020, I think that's what a lot of communities are wanting to see, right? A lot of constituents would get up there during open sessions and public commentary and say, we want our public safety to look different, and how. And this is a potential way to remedy that. And, I don't know if Dr. Lee has any more about how she strategically worked through that, but funding is always a tricky and necessary part of these conversations.
You mean we're not supposed to threaten our elected officials to pull the purse strings? Because you should have told me that 4 years ago, Caroline.
It's just being strategic. That's the way. Yeah.
You put it so eloquently. I'm telling people I have a condition called assertiveness, and then when I get in trouble, I just tell them it's my condition.
Right.
So to your question, what we did is we had a Burn JAG grant, so federal funding that was $2.145 million that funded 2 of our 3 mental health co-response teams through so federal funding. Second grant was Prompt 47, which was federal dollars that also came through the state to our county. And interestingly enough, it was actually the public defender's grant. And they felt so strongly in our ability to divert folks at Intercept 1 that at the expense of bolstering their holistic defense program and adding personnel, they funded a deputy position for us. And so when I say that this is a partnership, I really mean that. And that's one of the things that I'm most proud of with this program is we did not do anything in a silo. We walked arm in arm with NAMI, arm in arm with the public defender, with the community, persons with lived experience, criminal justice, jail, courts, all of that, and said, this is what we as a community and county really feel like will benefit our community members in our county. So the grants are ending December 31st. And so what we did this last budget cycle, which for us starts in April or May and concludes sometime in June or July, that period of time is usually a big blur for me. But we walked our board of supervisors. We took the data, we took the stories, we met with each of our county supervisors and had a one-on-one meeting to answer any questions they had, and then took it to a larger public meeting. And there was a lot of community and government support. And so what they are doing at present, just to get more nuance for those of you that are in this process, is they're continuing the 3 teams for 3 years with ARPA funding. That is the initial commitment, because ARPA funding, which is the COVID money that came down to help support some of the mental health stuff, if you will, our Board of Supervisors is using that to help support the continuation of this program. And then we'll go through the budget process again. We'll have even more data that can help us petition for the additional teams forevermore as line items. But because we were grant funded, what's often tied to grants is a component of research and evaluation. So we had to partner with UC Santa Barbara, our research and evaluators, and then social finance, who were really able to synthesize the data, put together some of the slides that you saw, which we used in our presentation to the Board of Supervisors to provide proof of concept to request additional dollars.
Thank you so much. It looks like we have not gotten additional questions. I want to thank everyone in attendance for posing such thoughtful questions and facilitating a really great discussion. And then, of course, I want to give a very big thank you to the panelists for your presentation and for such thoughtful answers to our questions today. I think this is a real testament to how much we really need to kind of explore this emerging best practice of having clinicians respond during crisis calls, whether it's with police or alone. There are some serious concerns here. And I want to thank you all for such a great discussion. Thank you to all of you listening in again for attending. And as a reminder, this webinar was recorded. Normally I would say it should be available early next week, but I do know that next week is the holiday. So I'd say if you haven't seen it posted in about 2 weeks, here's my email. Go ahead and feel free to send me an email. Again, just such a big thank you to all of the folks from the National Policing Institute, from Dr. Lee with the Santa Barbara County. Thank you so much. And I wish you all a great afternoon and a happy Thanksgiving.
Thank you. And thank you all.
Thank you.